In Chapter 25, we're going to be discussing the complications of pregnancy. The first we'll discuss is hemorrhagic conditions of early pregnancy. This includes abortions, spontaneous, threatened, inevitable, where the fetus never implants properly inside the uterine wall lining. Therefore, it is almost inevitable, if you will, pardon my use of the word again, for that pregnancy to become incomplete and turn into a spontaneous abortion. A complete abortion is a term used to describe an abortion that has left with all the products of conception, left the uterus, that is. A missed abortion is a term used to describe where partial products of conception are left behind in the uterus. Recurrent spontaneous abortions is another term used to describe a medical condition that patients can exhibit by having spontaneous abortions over and over and over through time, pretty typical with their pregnancies. For some reason, there might be a genetic component or something that is ongoing that does not allow that fetus to implant properly in the uterus. In the following picture, we can see some examples of a threatened abortion where towards the bottom of that uterus, where the cervix is, we can see some vaginal bleeding occurring. In that pregnancy, for some reason, there might be something ongoing in that pregnancy that has caused some bleeding, perhaps some issues with the placenta or something in particular that has caused some disruption in the embedment of that placenta that could cause a threatened abortion. Doesn't necessarily mean that that pregnancy will result in a complete abortion, but does put that patient for higher risk for such things. In the second one, we see that picture of that inevitable abortion that we had discussed, and then in the last picture, we see that visualization of an incomplete abortion. Other hemorrhagic conditions of early pregnancy include DIC, which is also known as disseminated intravascular coagulation. This is a very, 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 very obscure issue that can happen in obstetrics, specifically to the patient population here. It is highly life-threatening. It is a defect in coagulation, which causes inappropriate coagulation. The patient themselves may be experiencing a period of high loss of volume of blood flow. So in order for their body to try to compensate or have those platelets work hard to stop that blood flow, there is an issue of coagulation there. The coagulopathy does not work properly. So while the patient is bleeding, their clotting factors are not working properly, so they cannot produce an appropriate initiation of their coagulation factors to stop the bleeding. Tiny clots form in blood vessels, which create a change in how that blood plasma is comprised of. Patients who are in DIC crisis can be seen to be losing blood or having blood come from different orifices. So if they have an IV, they might have bleeding at their IV site. They might have bleeding from their nose, and this blood would appear very kind of clear and watery-like, and that's due to the clotting mechanism defect. Very, very, very high-risk situation. These patients usually end up in a SICU, which is a surgical intensive care unit, for some time after experiencing something like a DIC crisis. Other hemorrhagic conditions of early pregnancy include an ectopic pregnancy. An ectopic pregnancy is also something of critical importance because it is the implantation of a fertilized ovum outside of the uterus. Particularly these ovums or these zygotes or fetus, however terminology you want to use to describe the fertilized egg there, will implant perhaps in a fallopian tube or just towards the center, coming towards the uterus but not quite in the uterus. This can cause significant issues. As we know, a fallopian tube is not a proper place to have a zygote embedded and to have that fetus develop. So this might cause a patient to have some complications and maybe even a loss of uterine structure, a loss of fallopian tube, or some type of surgery to remove that implanted fertilized ovum. Gestational Trophoblastic disease is also known as molar pregnancy. That's where mole trophoblasts develop abnormally, so an abnormal fertilized ovum can implant and cause proliferation of cells, and it causes edema in the chronic villi of the uterus. And in slide 6, we can just see a closer visualization of the fertilized egg kind of moving through the fiblar, the interstitial space over there. On slide 7, we can see what an ectopic pregnancy removal would look like. So we can see there's an incision made in the fallopian tube. It is then removed. Those products of conception, it's not quite a baby, if you will. It is just the development of the products of what a zygote would be, status post fetal development. In slide 8, we have that representation of what would be a molar pregnancy. And we can see that it's inside the uterus there. Application of the nursing process in conditions in early pregnancy. So when we think about things that we want to really spend a lot of time kind of analyzing and seeing how it would impact the role of the nurse, we want to think about what our assessments would be like in a patient experiencing any one of the previously discussed medical diagnoses, such as a threatened abortion or DIC. How would the nurse assess that patient? Is the patient stable? Is she actively bleeding? What is her coping like if she's experiencing an abortion? And in particular, if she is a patient who has a history of recurrent abortions, what nursing diagnoses apply to these patients? And we talked about that blood volume loss. So these are patients that would be high risk for that volume instability there. What are the expected outcomes? How do we manage patients after a miscarriage, and what are the nursing implications there? How do we talk about, coping with the loss? Everybody copes and experiences loss differently, especially in miscarriages. Some patients can really experience it as a loss of a baby and have a lot of, negative feelings there, a lot of feelings of sadness, while other patients might have a different form of coping. They might not have seen that early development of a zygote as a baby. So there's different ways of coping, and each patient's going to exhibit that. What interventions would be important to consider for these patients, especially in somebody who's exhibiting DIC? Obviously, we want to make sure that we know their blood type. Do they have units of blood in the blood bank ready to go should we need to administer them? What kind of lab values would be important to follow for that patient, especially if they're having any kind of coagulopathy and issues with their clotting? It would be important to figure out what lab values we want to kind of track and observe, and how do we evaluate these patients as well. Hemorrhagic conditions of late pregnancy include a placenta previa. A placenta previa is a condition used to, the wording is a condition used to describe when a placenta does not implant in the appropriate areas or the appropriate quadrants of the uterus. When we think about the uterus, we think about it in kind of like a little square. So we go right down the center and then we cut it laterally as well. If that placenta has implanted in the lower segment of the uterus, and in particular over the cervix itself, that would be considered a condition of a placenta previa. The etiology of this is unknown. Some patients might be at higher risk for it due to increased uterine surgery, or patients who, let's say, have had multiple cesarean sections in the past, they'd be at higher risk for this. But some patients have it spontaneously, even with the first pregnancy. We always want to deliver a baby head before we deliver a placenta, before we deliver a baby bottom. So these patients, their mode of delivery would very highly likely be a scheduled C-section. Some clinical manifestations that we can see in these types of patients, especially, second trimester, third trimester of pregnancy, they might exhibit some vaginal bleeding, which would require monitoring, and perhaps even some monitoring inpatient in the hospital. And that's because that placenta has implanted perhaps on or near the cervix, and we want to monitor the blood volume of mom, as well as how that baby is doing. Remember that that placenta is that baby's lifeline for how they get oxygenated and deoxygenated blood, and it contributes to their growth and development. So if we ever suspect any type of compromise in the placenta, we want to be highly monitoring that baby's heart rate and how that baby's doing. Therapeutic management, as I had previously discussed, might require a C-section depending on how this patient's bleeding is or what this patient is presenting like. Other management could include prolonged fetal monitoring. Again, we want to make sure that that passenger is doing well. Some patients are stable enough with these conditions that they can stay at home, and some patients do require that inpatient care. In slide 11, we can see some visualizations of what a marginal placenta previa looks like, and that's where that placenta is embedded in the lower quadrants of the uterus itself, but not quite completely over the cervix. The last picture at the bottom of this slide, we can see a total placenta previa, and that's where that placenta has completely covered the cervical os there. Slide 12. Hemorrhagic conditions of late pregnancy also include an abrupto placentae. Abrupto placentae is also known as an abruption. An abruption is a term used to describe when the placenta comes away or tears away from the uterine wall lining. Abruptions could be caused by multiple reasons. For example, abdominal traumas on patients who are gestated could cause an abruption. An abdominal trauma could be from a car accident or an airbag deployment or even a fall in the home or outside. Clinical manifestations of an abruption would include sharp, sudden pain followed by heavy vaginal bleeding. Nothing in labor is sudden and sharp. An abruption is the exception there. The patient might not be in labor, but it is definitely sudden and sharp and also followed by heavy vaginal bleeding. Therapeutic management for these patients would include, in a true obstetrical emergency, it could include a C-section as a mode for delivery. When patients can exhibit smaller abruptions, if you will, maybe marginal abruptions or partial abruptions, they might have intermittent vaginal bleeding. They might not have pain, as the coming away from that uterine wall of the placenta might be small or minimal, so it might not exhibit as much pain for a patient as a complete abruption would. Those patients might be monitored inpatient in the hospital. Again, safeguarding that passenger in there, so we'd be monitoring that baby's heart rate and monitoring what mom's blood loss looks like. So for nursing considerations for these patients, again, remember that we are not just taking care of the mom who's pregnant, we're also taking care of that passenger. So we want to make sure that we're watching that baby's heart rate, assessing for any signs of stress, and monitoring any type of blood loss there. Slide 13, we can see some visualizations of abruptions. And the top would be a marginal abruption where we have that external bleeding there. And then a complete abruption, which is concealed bleeding in the bottom picture there. So that patient would not exhibit any vaginal bleeding, but I can almost guarantee you that that patient would be experiencing or would be exhibiting significant fetal distress if we had that baby connected to a monitor. Slide 14, application of the nursing process, hemorrhagic conditions of late pregnancy. So just kind of tying together some of the things we had discussed previously. Again, assessment is always going to be something that is highly, highly, highly important. And these are questions that they tend to kind of follow on the NCLEX there. Nursing assessment, want to keep our patients safe. What is this patient's baseline? Is she having bleeding? Is she uncomfortable? Was she in an abdominal trauma, like a car accident? And from there, we can kind of start to make our nursing diagnoses. Is this patient at risk for injury? What about her blood volume balance? What are some expected outcomes? Like I had talked about before, if a patient has a complete abruption with a significant amount of vaginal bleeding, perhaps that patient's expected outcome would be a cesarean section. What other interventions might be appropriate for these patients? Again, if these are patients that are at high risk for having high blood loss volume, we would want to make sure that there's blood products available, that there is IV access, and that these patients are aware of what the situation is. Hyperemesis gravidum is a fancy word for kind of saying extreme nausea vomiting during pregnancy. We want to kind of consider patients who have hyperemesis gravidum, and some patients can even be seen either outpatient or inpatient with this because we start to worry about their hydration. If these patients are unable to keep any fluids down, we really want to make sure that we safeguard their hydration. So some of these patients might be candidates for therapeutic management, such as Phenergan, which is an antiemetic, maybe some Benadryl to kind of like help relax them. A little antihistamine receptor can help some of those feelings of nausea as well, or any kind of gastric acid inhibitors. Some nursing considerations for these patients. We want to make sure that we educate them on some precautions that they can take. It's shown to improve feelings of nausea if they have clear sips of fluid, clear fluids. I wouldn't tell them to kind of, guzzle down a liter of fluid, but maybe small sips of fluid over a few minutes. I'd encourage them to maybe try different types of fluids, like maybe clear popsicles, maybe sugar-free popsicles, if that's appropriate. I'd also encourage them to eat small, frequent meals to see if that helps kind of keep their nausea at bay. Hypertensive disorders of pregnancy. So for the next couple of slides, that's what we're going to be talking about. That includes gestational hypertension, preeclampsia, eclampsia, as well as chronic hypertension. Hypertensive disorders in pregnancy also include preeclampsia, so that's the first one we're going to discuss. Preeclampsia is an illness that patients can experience during their pregnancy. It can present typically seen in the third trimester. Very, very, very rarely there is incidence of patients who exhibit preeclampsia in their second trimester. What's interesting about preeclampsia is that the reason it occurs is really unknown. The best research that's out there currently tells us that there is something about the placenta that is kind of almost like physically rejected from mom's body. And the way our bodies exhibit kind of that rejection during pregnancy would be elevated blood pressures, changes in mom's liver function as well. Some preventative measures that we can talk about with these patients would include health monitoring. So these are patients that we definitely want to make sure that they are seen in the clinic frequently, that we're monitoring their blood pressures, we're assessing for signs and symptoms related to preeclampsia that we'll discuss in a few moments. Therapeutic management of preeclampsia could include, again, full assessment. Is it in the mild range? And mild range is typically exhibited by blood pressures. Blood pressures in the mild range for preeclampsia can be about 150s over like 80, high 80s to maybe 90s. Mild preeclampsia would not have typically many significant other findings like severe preeclampsia will, and I'll just describe that in just a moment there. Those patients might have a recommendation for an induction of labor when they become term pregnant or full-term pregnant, which can start at about 37 weeks, and that can be provider dependent there when they choose to induce patients. But we know patients with mild preeclampsia have a risk of increasing blood pressures. They have a risk of eclampsia, which is a seizure during pregnancy. So in these cases, mild preeclampsia the recommendation is typically to have patients be induced when they are term in their pregnancy. Most patients with preeclampsia might be in the outpatient setting, and those patients might be managed from home. Inpatient management of severe preeclampsia. These patients are patients who have significantly elevated blood pressures. I'm talking about blood pressures greater than 150 over 90. Some patients require some IV blood pressure, some IV hypertensive medications at the bedside as well. These patients, I wouldn't be surprised if I had a patient who had severe features of preeclampsia to exhibit blood pressures of 180 over 90. These patients also have other exacerbations of preeclampsia, such as headaches that are unresolved with Tylenol. They might have some visual disturbances where they see kind of dots or little floaters in their vision. They might have severe epigastric pain, typically in the left upper quadrant. These patients are managed, like I had said previously, perhaps with some IV hypertensives, as well as with a recommendation for induction. In some cases, it might be safer to move towards a cesarean section. And in some cases, and again, this might be institutional, some places medicate their patients, both mild and severe, again, very institutionally dependent, with magnesium sulfate. Magnesium sulfate is the medication used to treat preeclampsia. Magnesium sulfate is a smooth muscle relaxer. It's an element. In lieu of element replacement, like you might have seen in med-surg, these patients are getting 2 grams, typically continuous throughout their labor course, to help relax the smooth muscles in their vessels, so that hopefully their blood pressure decreases, they might have less signs and symptoms of preeclampsia, and we're able to kind of manage that during the period of labor, as well as typically the first 24 hours after delivery, because that's when these patients are at highest risk for eclamptic seizures or seizures in the postpartum period. And very institutionally dependent where these patients are managed, whether outpatient setting, that might be mild preeclamptic, versus a severe preeclamptic would be managed inpatient. Postpartum, again, these patients will stay on magnesium for about 24 hours after they deliver their baby, depending on the institution they are, especially though if they're severe preeclamptics. And that's because they're at highest risk for seizures at up to 24 hours after delivery. On the next slide, we see a little representation of what a woman's body might exhibit when she has preeclampsia. So her blood pressure would increase, which increases that response to angiotensin II. She has a diminished cardiac output because of the amount of volume that's coming through there. She has an increase in systemic vascular resistance, but a decrease in plasma volume. That actually might cause some swelling. These patients, another sign and symptom of preeclampsia would be severe swelling, especially in the lower extremities. These patients might have +3, +4 pitting edema. They might exhibit some periorbital edema. There are a lot of edema in their hands as well, especially if it's sudden. It's very important for healthcare providers to know that information. In slide 19, we can just see some visualizations of that periorbital edema in slide A, and then that pitting edema in B. Things we want to keep in mind is highly important that we think about the nursing process when we're taking care of patients who have preeclampsia. Their assessment. So if we know what their baseline was prior, that's always helpful. But most often, these patients, once they come in with preeclampsia, we didn't really get to meet them prior to their diagnosis. So we want to kind of look and assess at their symptoms. We want to assess their swelling. Is it increasing? Is it staying baseline? How can we manage that, right? We want to look at other signs and symptoms. I talked about severe epigastric pain previously, and especially in the right upper quadrant that these patients might exhibit. That could be a sign of an encapsulated liver. It could be a sign of inflamed liver. So if a patient is continuously telling you, I have a lot of severe epigastric pain, and we try to give her some medication to manage that discomfort and is not alleviated by anything like that, that might be an indication for further follow-up with blood tests. How are her liver function tests? Are they getting worse? Are they improving? So that would definitely be a way that we can kind of assess, and we can find those nursing diagnoses that apply to that. Magnesium toxicity. I said before, magnesium is an element, and though we give it as the medication, the most popular form of medication for preeclampsia, it can kind of build up within patients' systems. Magnesium has a cumulative effect. So the longer it is running, the more mag-toxic these patients can become. So some signs and symptoms of magnesium toxicity, and knowing that would be important for nurses caring for this patient population. So what do patients look like when they have had too much magnesium? Perhaps their deep tendon reflexes are diminished. Because magnesium is that smooth muscle relaxer and the diaphragm is a smooth muscle, these patients might not be inhaling, exhaling, and having kind of as deep respirations as we would like them to. They could actually go into kind of a flash pulmonary edema. So we might want to assess their lungs for any adventitious lung sounds, such as crackles that we would hear with patients with fluid in their lungs or pulmonary edema. How are they feeling? What is their psychosocial assessment like? What are some interventions that we as nurses can do that would be important for this patient population, and how do we evaluate those interventions? HELP syndrome. HELP syndrome is the most severe form of preeclampsia. Very, 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 very severe form of preeclampsia. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. So if a patient is exhibiting elevated liver signs, low platelets, high blood pressures, these patients have a life-threatening condition. These patients are very high risk for exsanguination, very, very, very high risk for eclamptic seizures. This complicates about 10% of pregnancies, and again, the symptoms would mirror those symptoms of severe preeclampsia: the pitting edema, the severe epigastric pain, headaches unrelieved by Tylenol, visual disturbances, and again, extremely elevated blood pressures. Therapeutic management of these patients would mirror those of severe preeclamptics, with the exception of low platelets. These patients might be candidates for steroids intrapartum to help kind of increase their platelet number, and they might also be candidates for plasma or platelet repletion. Chronic hypertension. Chronic hypertension can be seen in pregnancy. I said earlier in the semester that it's not just healthy, well women having babies anymore. Sometimes we have patients that have other comorbidities, such as chronic hypertension. So it's always important to assess that patient's baseline. Evidence suggests that hypertension preceded the pregnancy, like I had previously stated, that comorbidity. So what are some effects when a patient has chronic hypertension coming into pregnancy? Do we worry about the blood flow to the placenta? And what are some therapeutic management that these patients can experience? Would they be on antihypertensives? Would we be monitoring them in outpatient setting or antenatally a little closer? So those are important things to consider. The last topic we'll discuss is the incompatibility between maternal and fetal blood. RH incompatibility can occur during pregnancy. So we learned last week that the fetal and maternal blood never mixes. And this kind of safeguards that RH incompatibility. But there may be some reason that it did interlace, maybe during the delivery, maybe during an abruption, so on and so forth. So some risk factors for mom would include that she would create antibodies in further pregnancies. So for this patient, it'd be highly important to have RhoGAM administered to them for that ABO incompatibility. We want to assess the baby for any fetal and neonatal implications, as well as kind of assess that mom there too. And we can see a nice little visualization there in slide 24. It talks about RH positive father and RH negative mother, and that kind of change in the antibodies there after birth if there is a cross of maternal and fetal blood there. You can see another nice representation of it as well in slide 25, 26, or a blood test for maternal RH factor, and what would be the plan of care for that mom if she is RH negative versus RH positive, so on and so forth. Okay, and then a last little kind of question to kind of tie all that information together. Which assessment finding would convince the nurse to hold the next dose of magnesium? So I hope that you'll be able to answer that with success after our lecture today.